soon as we want to start the webinar, looks like we've gone live.
Awesome. Looks good. Well, in that case, good morning, everyone, or afternoon or evening, regardless from wherever you're dialing in from. We'll take a few minutes to wait for everyone to dial in. I see a lot of attendees joining as we speak, and then we'll get going. So please bear with us for a few minutes as we get a quorum on all sides.
Welcome to the danger zone.
Hey, good evening, Nick. Awesome. Well, I see that there's still people dialing in as we speak, but we seem to have quorum on our side. So I think Bernice, feel free to kick us off, and then Bayeta, you can share the accompanying materials.
Great, thanks very much, Toivo, for this, and welcome everybody. We're very excited to welcome everybody to this event. It's one of a number of events that we've been holding on this specific initiative on the Homegrown Solutions Healthcare Accelerator for Africa's Pandemic Resilience. And I think today's event is a little less, how do we say it, a little less scripted than previously. And it's purposefully designed in such a way so that we really allow people to engage in a natural way with the first cohort of companies that were supported through this initiative, and really allow for the free flow of conversation and discussion. Hopefully something very interesting will come out of it and useful to everybody. So I think without further ado, we will just go into the introduction. I'll just the first slide in terms of I think most people who have been on Zooms now for the last 2 years or so, these are the socially acceptable things to do. So please mute your mic and your camera if you're not speaking. You're welcome to ask questions via the chat function, as you can see there on the screen where it is. And we have folks who are monitoring that and will alert us to that if there are specific questions that need to be answered. Please also feel free to use the reaction functions if you want to support something or wave at somebody or congratulate people and so on. And then if you have troubles asking questions, please just send through an email to that email address there, zoomassist@bcg.com, and they'll be able to help you with that. Just to mention that the Zoom is being recorded and all the communications will be saved. So let's, I think, go on to the start of the next section, which is just to introduce to you the speakers today. So I'll start with the cohort and then go to myself and BCG team. So you'll see the representatives of the companies that have been through the rounds of this acceleration. We have Daphne from Access Afia, Nick from AHN, Francis from Damu, Ronique from Revital Healthcare, and Innocent, last but not least, from NSCAN. Now, these are really exciting companies that have really taught us a lot in terms of the design and the function of what we're doing, and hopefully have really informed the way in which we will go about the next phase of this initiative. From the AUDA side, the African Union Development Agency, we are an African Union institution, as it says. I am the acting head of industrialization within the organization in the Directorate of Program Delivery and Coordination, which basically just means that we are trying to implement priority projects for the continent. Unfortunately, my colleague George is not able to be with us today. He's traveling, doing practical things on the ground. So it'll just be me today, but he is the project manager of this initiative. So if you have any further questions and comments and so on, please drop him an email. And then we have Toivo and team from the Boston Consulting Group, very able, excellent team of technical support on the project who've really been running with the technical aspects of it. Toivo, I'm not sure if you want to just say hi quickly.
Hi quickly. No, it's fun. I think the interesting bit that we'll get to is these companies presenting what they've been doing, but hope that Bernice and I can also shed some light on the accelerator first.
Great, thanks, Toivo. Okay, so let's move to the next slide, I think. We'll start with just telling you what we're going to be doing for the next couple of hours. We'll start off with an intro, just basically telling you about the accelerator, how it's worked so far, what we aim to do, and our plans for the future. And then we will go into the exciting part of the engagement is for the presentation by the companies themselves, and then a fourth section on engaging directly among ourselves for you to learn more about specific aspects. If you have any questions that you want to shoot directly to the companies or the representatives of the companies, and just to have a free flow of engagement and see where that goes. So thanks very much. Next slide. We'll just start with an overview of the accelerator, how it started and why we're doing it. So just in terms of very brief background in terms of why this started. Obviously, everybody knows there's a global pandemic. Our organization, AUDA, had a pandemic response plan that was developed to try to prioritize where we could help countries in the continent to respond to the pandemic. its attendant risks. And this accelerator concept developed out of that, and really drew from an ongoing partnership that we as an organization have with JICA, with the Japanese partnership, and was really as a response to helping the continent to respond to the pandemic by strengthening the healthcare system's resilience. So as you can see by the slide, the youngest continent of the world, we were hoping to try to help to strengthen the healthcare entrepreneurs, who are the feet on the ground in terms of actually doing stuff and really moving fast to address some of these the issues and the driving forces that were faced through the pandemic, interruptions of supply chains, weak healthcare systems, access to medical facilities, and so on. So the design of this initiative is really looking at how to address some of these key threats and challenges, but also the innovations from the continent, because we know that there's a lot of innovation going on. But in terms of support to innovation for young companies or small companies, this has proved challenging for them to really scale up and make a difference. So you'll see that the main problem that we're facing, as I mentioned, is the contrast to mature sectors like fintech or energy, where there is already a strong support and a strong ecosystem for support around these particular priorities. On the other hand, the healthcare sector venturing is still lacking across the continent. I think the public awareness of the need for this has really ramped up over the last couple of years. So the intent was to try to see how we can facilitate this process, how we can add value. So some of the challenges, as you can see there, for the growth and entry stage companies, as opposed to the mature stage, is really it's difficult to find the right partners, to access capital, to access technical advice, and also to understand or navigate the regulatory and legal frameworks around procurement and trade and scaling up across borders. So these were some of the key problem areas that came out from an initial analysis of what we were needing to address. So if we can go to the next slide. So what came out of a sort of an initial design baselining in terms of who's doing what globally and also on the continent in terms of acceleration for the healthcare system and what is needed, we designed a pilot initiative that is looking at accelerating African solutions, African companies, to increase Africa's resilience, that will be able to tackle the challenges that were mentioned in the previous slide, and then strengthen Africa's ability to respond to not only this pandemic, but also to future shocks. In terms of a focus area, as you can see there, we're looking at healthcare companies in the pilot phase, through providing tailored hands-on acceleration support across the four areas of challenges that were mentioned previously. And in so doing, we've assembled a consortium of leading organizations, also across both public, private sector, to try to deliver on that promise. And as you'll see in terms of the design of the governance of the accelerator, we have a very wide range of stakeholders and partners on it. So thanks. Just in terms of the pilot, this is we're piloting it in East Africa, and we started with a small group of 5 companies who are here today. And then we're hoping to scale up as time goes on. So I won't go into detail on this slide, but just to mention that we're looking at growth and mature companies. Specifically, we identified these stages of companies to make sure that we could make a difference very quickly through the pilot initiative. Because obviously there was an imperative and urgency to try to respond to the pandemic issues. So we were looking specifically for scaling and agility to respond to this. So those are specific criteria that you can see there on the main part of the slide is really how we focused in our efforts. So looking at the health sector, looking at priority solutions, the company stage, specifically from Africa or Africa focused, and looking specifically at the pilot in East Africa with a view to expanding in the next phases. Okay, so as many might know, acceleration support can come in different shapes and sizes and so on. In terms of the challenges that we had identified and our criteria for where we would add the most value, we had limited our acceleration to 4 main areas, specifically with an intent to provide really tailored acceleration through a plan that was developed in consultation with the companies themselves, to agree on specific areas of need for the companies themselves, and to roll out against these 4 different components that you can see here. So looking at context-specific advisory services. So I think many of the companies that you'll speak to today will speak about how their business models have either changed, adapted, expanded, focused in through the working directly with specialist consultants to assess what was needed for the companies, what their vision was, and how to move forward. In terms of the investment and funding support, really looking at, again, the business models and what was planned for the companies, and what may have been needed in terms of business facilitation, in terms of access to funding and investment. So here, looking specifically at how we could broker introductions further to high potential funders. And I think in 2 of the cases we've been quite, the companies have been quite successful in outlining what they need and having a successful outcome of that, which is really great. In terms of the regulatory and trade facilitation, as I mentioned earlier, there's a complex ecosystem of rules and regulations and laws and policies and so on, has really is difficult for many of the small companies or smaller companies to navigate, particularly if they're wishing to scale their operations across from one country to another or different regions. So really helping to try to facilitate this and escalate the regulatory issues to policymakers and make the connections with between the companies and the policymakers. The last component is looking at how to match with strategic partners. So identifying the right partner or the relevant partner that may be able to facilitate an unlocking of the company's growth to scale, and then also brokering introductions to these partners through our rather vast network that comprises potential advisors, mentors, partners, and so on. So I think this has also been one of the really added value aspects of the accelerator. All right, so next slide, please. Now, in terms of the design of the accelerator and leveraging from the both existing partnerships and collaborations of the 3 partner organizations and beyond, and by 3 partner organizations, I mean AUDA, JICA, and BCG. We have rather excitingly, I think, set up a broad ecosystem of different partners, both in the public and the private sector, and tried to connect the two, really with the vision of bringing on any partners who may be interested in both investing or assisting or leveraging or somehow being involved in the acceleration to be able to add value and assist the companies that we were working with. I won't go into detail around here, but you can see both sort of global as well as continental, regional and local institutions that are involved in the different governance structures of the accelerator. We have a steering committee that is led at the highest level by many of the continental role players in the health sector and the development sector, as well as private sector engagement. We also have an advisory panel that provides ongoing support and engagement. And then we also have different governance structures internally to make sure that the project rolls out smoothly and that the collaboration is very well coordinated and is going smoothly and as rapidly as possible. So next slide, please. All right, so as I mentioned earlier, we had started as a direct result of the pandemic response, our internal and pandemic response plan, which was really to move very fast to design a pilot that could facilitate a learning by doing approach and inform subsequent phases of scaling of this accelerator. So we began in 2020, to the latter half of 2020, where there was a baselining sort of research component that looked at what was going on and what was needed and how to actually inform the design. So very much an evidence-based design process. And that led to the selection of a small cohort of the 5 companies that you've seen here today, based in East Africa as the pilot. As I said, learn by doing model to inform next year's expansion phase, where we're looking at geographical expansion across the continent, in other areas of the continent, and then hopefully 2023, looking at what we call a steady state, where we have our project structure really firmly developed and operating as smoothly as possible, and are able to continue to expand our partnerships and collaborations, as well as add value to a greater number of companies across the continent. So I think that's pretty much it. Just next slide, please. Yeah, so I think that's it for the introduction. I'm not sure if there's a need for any questions or answers at this stage, or if we should just go straight into the presentations. Tove, maybe I'll hand over to you to take us forward from here. Thank you.
Perfect. Thanks, Bernice, for giving that introduction into the accelerator, where we're going, and how we're thinking of scaling this up also over the next couple of years. Yeah, as Bernice mentioned, if there are any questions, pop them in the chat, especially now when we go into talking about these companies themselves. We should have time for 1 or 2 plenary questions on each. But also feel free to hold off, and after this, have a more sort of meet and greet. You can put your own camera on and talk to these entrepreneurs themselves. But yeah, so as we move on to this next section, we want to give the floor to each of these 5 companies we've had the pleasure to work with this year. And I'll go in this order. So I'll start with you, Daphne. I know we're already a bit beyond schedule, but that's absolutely fine. We have plenty of sort of time for the meet and greet at the end. So I'll try to time box a bit around 10 minutes, including a question or 2 on each. But without further ado, then let me just hand it over to Daphne, who's the CEO of Access Afia, to talk us about what they're doing and where they're going. So Daphne, please.
Thanks, Toivo. Morning, everybody. I'm Daphne. I'm the CEO of Access Afia. I'm really excited to be here today to share a bit more about the work that we've been doing. A lot of it through the support that we've got through the ADA Accelerator. And so, by way of introduction, Access Afia has designed a model for localized primary healthcare for the global mass market. That serves the needs of low-income people. And so what we've developed is a physical and digital healthcare network that uses asset-light clinics, telemedicine, patient health data to engage patients throughout their healthcare journey from the diagnosis to treatment. You can change slide, please. So if you live in low-income communities today, healthcare is typically unavailable, unaffordable, or low quality, with long wait times at clinics. An average cost of private healthcare costs up to 8 times the average daily wage of a low-income earner, while medication stockouts and healthcare worker strikes are not uncommon in public facilities. Change slide, please. And so this is a problem that we're solving for an estimated 6 million people, and this is a population that is expected to triple by 2050, with primary healthcare spends growing 25% by 2025. And so solving for access to primary healthcare then for us presents a tremendous opportunity. So Access Afia solves for unavailable, unaffordable, and low quality care through this brick and click model that combines physical clinics with a digital presence. And this allows us to address all our patient needs across the primary care chain. So it takes less than 15 minutes in terms of travel time. Our facilities are conveniently located in communities that we serve. The cost of care is on average $4 for a visit, and an average wait time of about 33 minutes, which is really essential for informally employed wage earners for whom a day's wages lost is quite significant. And in terms of quality, maintain high availability of stock, maintain 99% stock availability. And we also have a virtual clinic. This is available as a progressive web app and on the M-Pesa super app, as a mini app on that super app, that allows us to provide access to consultations for $3 a consultation for people within and outside of the immediate target market that we serve. Next slide, please. So typically a patient, hears about us from their community. So they might hear about us when they're taking their blood pressure, doing a blood pressure screening with a community health worker, or increasingly, triaging themselves on their phone. And they visit they're nudged to visit an Access Afia clinic based off of the results of that, where they can get a consultation, diagnostic test, and medications. And then they receive follow-up on how they're doing, so they're able to tell the doctor how they're doing, and this information is again used to triage them and keep them in care. Conveniently, if a patient has a need outside of physical visits, because care does not start and stop at the clinic, as we know, is able to access their provider, their doctor, on M-Daktari. And our custom tools then follow the patients through this journey, keeping them in care and monitoring their outcomes. Next slide, please. So how this all kind of comes together is through first standardization and digitization. So our clinics use custom patient management software, health CRM, to analyze health data for the individuals that we serve, looking at 25 plus data points, all of which help clinicians make accurate and informed decisions and provide the right treatment options. Our virtual clinic is also a custom tech custom solution that we have that provides increasing access outside of physical visits. So creating a first point of contact beyond, walking into a health facility. Standardization on the scope of primary care services available, quality management helps to keep care consistent and also consistently run lean operations. And then franchising takes our model, takes the best of the model and scales it. And we do this through aligned incentives between the franchisees and lending them the lean setup and central support, business support that healthcare workers need. Next slide, please. So we have served in terms of where we sit, so we've really differentiated on affordability, quality, and accessibility of our services. So against, on private, regular or more familiar private health sector side, our visits cost an average of $4 compared to an upward of $12 to up to 8 times the income earning capabilities of the market that we serve. Beyond digital solutions offer more comprehensiveness and a physical touch point where patients can actually come and receive additional complementary care that the digital services are not able to provide. In terms of affordability, we differentiate against the other players here through a more comprehensive service. For example, provide diabetes and hypertension services, full scope from awareness to management at 15-minute kind of proximity to communities and short wait times. Next slide, please. So we have served 300,000 people to date through 15 locations in 4 counties in Kenya. We acquired a chain of franchise clinics, and in about a year and a half now, we've tripled their profitability. Our virtual clinic, next slide, has had early signs of traction with partnerships that we have with Safaricom. Next slide, please. So early signs of traction there with consistent, 1,500 registrations and interest per month, consultations and B2B partnerships that are growing that. Next slide, please. Our community outreach and impact has significantly grown. Our diabetes and hypertension program has grown 10x in the last 4 years. Our patient self-reported recovery rates have been quite consistent. So really underscoring the importance of primary healthcare and effectiveness to manage and triage to higher levels of care the kind of primary care patients that we see. And in terms of patient satisfaction, we've had increasingly good patient satisfaction up to 70 against an industry standard in healthcare of 17. Next slide, please. So we have had, kind of several recognitions which are really great around some of the areas that we've really put a lot of focus on in terms of our customer experience, alignment to universal health coverage, and really making sure that care is as comprehensive and affordable as possible. In terms of quality, in terms of the use of information technology to both build the efficiency and use that to improve patient outcomes. So this is something we've developed for diabetes and hypertension that manages the patient from their first point of contact, screening with a high blood pressure, through to their outcomes in terms of their, is their blood pressure controlled, is their blood sugar controlled? And then in terms of quality, our clinics are rated top amongst 400 primary healthcare facilities in Kenya. Next slide, please. So we really are at an inflection point. So with our profitable franchise clinics, we're really looking to start to batch scale the franchise clinics in the next year by doubling the size of our network to 27 new locations, and continue to grow much faster after that. Next slide, please. So franchising, as you can expect, is we're looking to grow 12 sites and double the rate of growth thereafter, but really require tenure to scale, and they're projected to be EBITDA positive by 2025. Next slide, please. And as a company, achieve full break even by 2026. Through our main business lines of Curafa franchise, our branches that we run, currently 6 of them, telemedicine and B2B, as well as SaaS and analytics. So we have a diverse team with a broad range of, that brings a broad range of experience across urban development, digital health, healthcare management, informatics, and startup business development, as well as support from incredible partnerships from government, private sector, and not-for-profit. So we are at a point of growth and our first kind of phase of growth, and we're looking to raise $1 million to supercharge the traction around our franchise business and hone in our technology developments on our technology products that I mentioned. Also looking to reach 600,000 people by the end of 2022. So that brings me to the end of just that brief overview of what we're doing. Again, really happy to have gone through this accelerator, and I look forward to any of your questions after this or in the breakout sessions.
Great, thanks, Daphne. I think we can take one question already, and there's one that was sent to me directly, so I'll just restate it. And that's Daphne, how did you guys end up at the price point you are at right now? Because I imagine it's like, walking a tight line between making yourself financially sustainable, but also providing access to these communities.
Yeah, so it has been a kind of lengthy process of innovating on this axis of cost, quality, and affordability, and with a majority of our patients, pay, and in Kenya and a lot of African countries paying, underinsured and paying out of pocket, then affordability is a key part of that. Regardless, I think there's also a need for regardless of the payer, be it individuals, be it governments, be it health financing, insurance, the affordability is a key question on everybody's mind. How do you make it work for the value that you're creating and the outcomes that you desire? So really, it's been kind of innovating around that, from the design to the clinic, the workflows, the team composition, the use of technology, the use of the information to generate service and business improvements, culture. So everything, kind of, very deliberately, and also, kind of just really applying principles in general around training and culture and mission alignment, etc. But the core of it is around the standardization, the digitization, and then the replication.
Great. Thank you very much for the presentation, Daphne. I see some other questions come in around the franchising model, but I propose we hold those off for the sort of breakouts later. And with that, continue moving down the line. So thanks again, Daphne.
Thank you.
Great. So then next up, staying in the corner of healthcare delivery and sort of brick and mortar presence, Nick, I'll hand it over to you to talk us through what Africa Healthcare Network is doing. So Nick, please, over to you.
Great, thank you. Tough act to follow, Daphne. Thanks a lot for laying me up. So a pleasure to be introduced to everyone, and thank you for the time. My name is Nick Pereira. I'm the CEO and co-founder and director of Africa Healthcare Network. Next slide, please. So Africa Healthcare Network was started in 2015 with the goal of creating the largest provider of renal care and dialysis services across sub-Saharan Africa. And we were basically built on three pillars: increasing access to care by bringing dialysis outside of just the cities or the capital cities and moving into more rural and semi-rural settings, increasing awareness, and so that's both preventative education for patients suffering from kidney disease, improving capacity building by training nurses, physicians, nephrologists across the region. And then finally, also improving the affordability of care, as dialysis care is one of the most expensive healthcare interventions globally. So over this time, effectively, we built our organization by really working with leading healthcare organizations across East Africa, heavily focusing on faith-based hospitals, highly focused on the patient care experience, similar to what Daphne is doing, and then really ensuring that we're building high-quality teams that are locally run across the countries in which we operate. And in those countries, as it stands right now, are Rwanda, Tanzania, and Kenya. Next slide, please. So the way we work is we are effectively a hospital inside a hospital. We are an outsourced provider of renal care, similar to those of DaVita, Fresenius that operate globally, whereby we partner with hospitals and effectively tell the hospitals, give us 4 walls, water, and electricity, and we'll take care of the rest. And what I mean by that is we will, in fact, even build from the ground up brand new dialysis facilities up to 250 square meters in space, purchase all the necessary medical equipment, dialysis equipment, water filtration equipment as well to outfit the units. We manage all the training and staffing of the centers, from everyone from the cleaning personnel to the nursing assistants, nurses, all the way to the nephrologists. And we also ensure that all centers are well stocked with consumables. And so the big value add though that we look at is the fact that we continuously adhere to the international standards to ensure that we're bringing the highest quality of care to the patients in the regions that we serve through rigorous SOPs, close clinical oversight, and continuous focus on our KPIs. Ultimately, for the hospital, the way the hospital benefits is we create a captive patient population, as by having a dialysis center, it further makes the hospital a one-stop shop for comprehensive care. The hospital, in addition, gets revenue share, and then on top of that, receives ancillary revenue from the patients who come, even for consultations, also for dialysis, from the lab, diagnostics, pharmacy, and also inpatient as well. So over the past,
Nick, it seems we are losing you somewhat. Perhaps it might stabilize if you turn off your video for a second. Everyone, let me just ping Nick offline. Unfortunately, it looks like we lost Nick here for a second.
I think I'm back on.
Perfect. Great. Yeah, Nick, I'll let you know if there's any issues again. Feel free to turn off your video if that stabilizes things, but please continue. Thank you.
That sounds good. It's always good to be the embarrassing drop. So over the past 6.5 years, we've grown across East Africa, opening 25 facilities with 3 in Rwanda, 16 in Tanzania, and most of our expansion into Kenya with 6. And as we look forward over the next 3 to 5 years, by next year, we aim to have about 40 centers, both signed or operational, and then kind of the sky's the limit as we look to get to 100 centers over the next 5 years. In Rwanda, as it stands, we're treating about 50% of the patients on dialysis in country, and in Tanzania, about 5%. And we hope to replicate that as we move to continue to grow in Kenya and beyond. The other countries we're looking at right now are Uganda, Ethiopia, and the Southern African region in Zambia, Zimbabwe, Botswana, and Namibia. So those are all target countries for us in the future. Next slide, please. So just to go to a couple of the elements that make us a little bit unique in this space, especially in that of specialized care. We are probably the only provider of healthcare services in East Africa that is completely vertically integrated. So we have our own supply chain network. We have warehouses in Dar es Salaam, Arusha, Nairobi, and Kigali, which allow us to directly source all of our consumables, our injectables, and medical equipment from the manufacturers. And as we've grown, we continue to look for new partnerships, which has allowed us now to source consumables and machines at a 30 to 70% discount relative to both the private sector and government and faith-based hospitals in the region. So this is what allows us to give the favorable economics as well to our hospital partners. Next slide, please. But ultimately for us, patient care is top of mind and sustainability is top of mind. So a couple of the key areas that we've seen hospitals struggle historically has been having a significant lack of clinical expertise. So we've created our own training institutes, both in Dar es Salaam, in Arusha, and most recently we're launching in Nairobi, which will be accredited and able to provide both degrees and CPD points, continuing professional development points. We've built the largest network of nephrologists in East Africa, working with about 15 or almost 40% of all the nephrologists in the region. And we have also, just to ensure sustainability, we have the largest team of biomedical engineers who are fully trained on all the equipment that is used within the dialysis center, which has allowed us to have zero downtime. In fact, we, knock on wood, in the past 6.5 years, we have never stopped operations for even one day. And you look at government hospitals and compare, often hospitals go down multiple times in a year due to inability to manage the renal units. And I think the biggest point of pride over the past 18 months has been the fact that during COVID, and still during COVID, we were able to achieve a zero COVID-related mortality amongst our patients who were receiving care. Now, this is unique because dialysis patients have the highest mortality rate of any type of patient if they were to contract coronavirus. Next slide, please. So just to skip through this rather quickly, overall, our team has over 100 years of expertise in the healthcare space. We're led by our chairman, Dr. Brian Pereira, who is one of the leading nephrologists globally. He was president of National Kidney Foundation in the US and actually helped found KDIGO, which is Kidney Disease Improving Global Outcomes. That is effectively the board that has set the international standards. And we have our other co-founder, Dr. Lloyd Vincent, who is a nephrologist and one of the most senior nephrologists coming from India. Across that, we have, over the past 2 years, really worked on strengthening our bench and focusing on building a strong team. And that's something we've worked extensively with BCG over the past 6 months as we look to our org structure to ensure the organization survives, both myself, our other co-founders, but generally the AHN name is around decades from now. Next slide. And so finally, we're in a unique position because we're actually not looking to raise any capital right now. We've had the pleasure of a great equity partner in Asia Africa Investment Consulting, who is currently our largest institutional shareholder. The rest of the company is owned by the co-founders and the employees. And then finally, most recently, earlier this year, we had the pleasure of partnering with the Development Finance Corporation of the US government to take debt up to $5 million, which you can draw over the next 2 years for a 7-year tenure. So we're extremely excited about our partnerships. We believe we're well positioned to grow, investing our existing recycled cash flow into growth, along with the debt and equity capital that we've raised over the past 12 to 18 months. So I'd say with that, I'll open it up to questions. And I'd like to thank BCG for the work that's they've done with us to really bring us from the startup phase to really looking at ourselves as an organization more in the growth equity phase.
Awesome. Thanks for that, Nick. Anyone has any questions, feel free to drop them in the chat. Let me otherwise just list the one I've received already, which is a sort of a more wider question. But as you guys are now operational in a few countries, there's obviously a bunch of things that are hard in sort of expanding across countries. But what is the one that perhaps was most surprising or that stood out to you most?
That's a tough question. I'd say the model has not been difficult to replicate, but every country you enter into is almost like starting a new company from scratch. So I think that the hardest part has been timing our entrance into new countries, especially when you enter in an organic way. It's 12 to 18 months before you can even launch your first center and begin bringing revenue in. So you have to have a lot of foresight when it comes to that. And so even as we look to expand into Uganda and other countries, while we are not planning to do any expansion or opening these centers now, we're already beginning the process. And so I'd say that's probably number one toughest, is just the fact that it's effectively starting a new company. But there are also a lot of similarities, especially in the East African region. So I'll leave it at that.
Great. Cool. Thanks for answering that, Nick. And I think there's another topic that's come up a few times on working with governments that I've even seen you've raised that might pose at all once we've finished going through the list. So thanks again, Nick. And let's continue moving. So then the next company coming up is Damu here in Kenya. And Francis, if you're on the line, please feel free to go off mute and walk us through what Damu is doing.
Thank you so much, Trevor. First, I would like to thank everyone who has participated in converging this, and I would like to thank BCG for the role you have played in shaping us up. This is really going to serve as a great springboard towards our objectives. And also congratulations to every company that is here for the great contribution you're making towards making the difference in the world. So without so much palaver, I would like to go to my presentation. Next slide, please. So the story of Damu was inspired by the Westgate Mall attack of the year 2013, whereby we had unstructured blood appeals in the country. And there is this one example I love giving, whereby you have someone in a remote place in Kenya who has had, maybe over the radio, the need to donate a unit of blood for a terror victim who is here in Nairobi, but that person has never come to Nairobi, or maybe they do not have transport. So the concept was, how can we empower someone who is in a remote place in any part of the country to be able to donate blood for a victim who is in Nairobi? And so there was a need for us to be able to make it possible for the hospital's blood banks to see one another in the blood services ecosystem. And with that concept, we got a chance to be part of the presidential digital talent program that was started by the president here in Kenya. The objective was to give an opportunity for the youth to come up with the innovations that can make a difference in any sector in the economy. And Musasa was among them that was targeting the healthy sector, specifically the blood services value chain. So we piloted the solution at the Kenyatta National Hospital. The pilot was supposed to last for 2 months, according to our concept, but we ended up there for 2 years because we found there are other challenges that it built as the blood services ecosystem, besides what we thought about. And this is all about how blood is sourced, how it's requisitioned within the facility. And so we went down to address those intricacies that contribute to the insufficiency of blood in the blood services value chain in the long run. And we ended up getting recommendations from Kenyatta National Hospital, which was our home in terms of building the solution. Recommendations from Ministry of ICT, where we started. And then we have risen up to support over 105 hospitals in the country currently. And yeah, so Kenya, that's where we have mostly set our base. And I will be explaining more in my succeeding slides. Next slide, please. So our objective is to facilitate timely and equitable access to safe blood for transfusions. Damu Sasa, in a nutshell, is an end-to-end blood services management platform. We are built to aid in effective management of the blood services, whereby, like I said, we look at the processes right from sourcing of blood all the way to the transfusion. So we ensure that every unit of blood is listed, tracked. We connect those blood units to the blood donors, transfusing facilities, logistics providers, and the regulator, and the Damu Sasa platform that can be accessed by all, anywhere and anytime. Next slide, please. So that's an overview of the blood services ecosystem, which is comprised of various stakeholders. We have the government as the regulator, as I mentioned. Then we have other hospitals, which are quite many of them, which transfuse patients. Then we have emergency response teams that courier blood from one facility to another once a facility does requisition. And everything that happens within the blood services value chain, anything that any stakeholder does, it's for the sake of the patient, who is usually at the center of the ecosystem. So I would like to explain how we went down to have value for any stakeholder within the blood services value chain. Next slide, please. So the challenges of the ecosystem, we have challenges in blood sourcing, how blood is sourced. We have challenges in donor relationship management, and this is actually the biggest pain points that we have as far as the blood donation is concerned, whereby where we expect donors to go to donate blood, you find that the relationship is not quite ironed out, and that's why we have stereotypes around donations, where people believe maybe if I donate blood, I'm going to get an ailment. If I donate blood, I'm going to die. So we are trying to educate donors. Once you donate blood, it's no longer transactional, whereby you just donate and then you're given maybe soda and bread. In our case, we ensure that we engage the donor on an ongoing basis, whereby eventually we're able to convert these family donors, someone who was motivated to come and donate because they have a relative in a facility, to end up becoming a frequent donor. Yeah, you make them, you understand their behavior, hence you end up converting them to a frequent donor. And there is a high likelihood for this donor to turn up again once they are reminded to come and donate blood. And in facilities that we are currently running, I would like to give an example of Kenyatta National Hospital. For example, the conversion stands at 47%, whereby we are saying someone is no longer a family donor, they are now a frequent donor. They can donate for anyone in need of blood within the blood services value chain. Then we have challenges in terms of inventory. How is blood managed? Are you able to alert the people in charge, maybe when a unit of blood is about to expire, challenges in transfusion management? Are we able to capture data on real-time basis so that with this data we can empower data-driven decisions around blood transfusion management? Then we have challenges in reporting, which hinders the aspect of planning, because if I do not have reports on timely basis, I'm not able to make decisions on timely basis as well. And this, you find that cumulatively affects proper planning in the blood services value chain. Next slide, please. Now, the Damu Sasa solution has got various functions, and the first function is on the donor room functions, which in this case is known as the blood transfusion unit in a facility setup. On the clinical benefit side, under donor room, we empower the blood transfusion unit to have access to registered donors within our network, which can help strengthen further within new donors that walk into the donation room. Number two is that we're able to reach out to donors at a moment's notice, hence increasing the availability of donor during insufficiencies, which can now translate to an increment of blood transfusions. Then under clinical functions, we're able to minimize the likelihood of transfusion reactions and blood-borne disease transfusion through multiple rigorous checks, whereby I will be explaining that in my next slide, but just the point I would like to make on this is within the laboratory, you reduce the likelihood of blood unit expiration and cold chain violation. So if we are saying, for example, once blood is requested from the blood transfusion unit and it's supposed to be transfused within 30 minutes as per the WHO policies, we are adhering to that. So we are able to ensure that the people in charge of those specific areas are able to adhere to that. Next slide, please. Just populate it all. Now, and so the Musasa solution has got 6 modules. The first module is the donor relationship management module, referral management module. There is the internal management module for screening and inventory, which I'll be explaining into brief in my succeeding slides. So you can move to the next slide, please. But those are the modules that comprise the Musasa. So under the donor relationship management module, this is what happens. When a donor walks into the facility, their specific donor information is captured on the Damusasa platform, whereby you're able now to do targeted donor recall. By targeted donor recall is whereby, for example, if I'm in need of blood group B+, for instance, I can only target B+. I don't need to just call out donors, you know. I can also target a specific geographical location. Yeah, and that's why I was saying, like, if you look currently on how blood drives are run, what informs someone to run a blood drive? They can go and set up a tent where there is a lot of people gathered maybe in town, but you see, that's not scientifically driven. But if I'm able to run a blood drive targeting a specific geographical location where I'm sure if I target this place, there is a high likelihood of me getting blood group O negative, for example, you know, data is informing me because when these donors came in, I was able to capture all those details on an ongoing basis. Then there is aspect of donor tracking, whereby, for example, if a donor, for example, today walks in a facility to donate blood, for instance, maybe they were found to have an ailment, for example, they are not eligible to donate, for example, you refer them to a secondary care facility. Maybe if that donor tomorrow decides to go, let's say they went to Mpisha Hospital, for example, to donate, for example, but they were referred to a secondary care facility. And then maybe tomorrow they go and donate blood again. They go and intend to donate blood, let's say in Aga Khan Hospital. They will find that they have already been referred from Mpisha Hospital. So the lab manager there is not going even to waste time trying to check whether this person is eligible to move to the donation or not. Then there is the donor deferral. Donor deferral, this is usually temporary, whereby, for example, if you consumed alcohol last night and you have turned up to donate blood, for example, you can be deferred, let's say, for 10 days, 20 days. And if you go to another facility and you intend to donate blood, you'll find the system has not cleared you, because it's an ecosystem that everyone is integrated, and always you can monitor donors within the blood services value chain. Then there is a targeted donor appeal, which I mentioned. So essentially, the donor relationship management module is like an interlude between the public and the transfusing facilities to understand the donor always. Next slide, please.
As you go to the next slide, Francis, just alerting you that we are at the 10-minute mark, so kindly hit on the main points. Thank you.
Okay. So we also have an app that supplements the donor relationship management module. So this is mostly to reinforce the aspect of targeted blood appeals, blood donation centers referencing, blood donation appointment booking, blood donation feedback to donation centers, high opening health reviews that we do together with the professionals in those facilities, the doctors, the nurses, and the lab technologists. Then there is the aspect of community participation, where Kenya Red Cross comes really in handy to educate people on the importance of donation. Next slide, please. Also, we have a USSD for those who do not have a smartphone to download the app. Next slide, please. So within the clinical area, within the hospital setup, this is how we monitor the aspect of utilization of blood to empower us to capture the aspect of data. Remember, I spoke about sourcing of blood all the way to the transfusion. So essentially, this is what Damusasa is able to do now in depth within a facility, whereby we interconnect the nurse and the blood transfusion unit, whereby they're able to make requisitions of blood online, and then we're able to monitor that requisition, whether once blood has been issued, we're able to monitor it on real-time basis to ensure that it was transfused. If it was not transfused, we're able to call it back. Next slide, please. Also, this is how we monitor the aspect of inventory management, whereby we ensure units of blood do not expire. We always, the system can always alert the lab technologists whenever they are running low of a specific blood group, and then you're able to replenish the stock. Next slide, please. We have partnered with the Postal Corporation of Kenya on the aspect of logistics to ensure that you can scan the ecosystem and you're able to see your neighbor, what they have. So the concept is like Uber, how Uber works. So you are looking for blood group B plus in a facility setup, you scan the ecosystem and you're able to see within a specific proximity, there is a unit of blood available, let's say in Gertrude's Children's Hospital, in Jacaranda Hospital, and then you're able to dispatch a motorbike, for example, instead of an ambulance, which could get stuck in traffic. And maybe you have a delivering mother who is waiting for that blood. So if you dispatch a motorbike, there is a high probability, or rather the turnaround time is really awesome, whereby you can get it within 12 minutes instead of maybe 1 hour or 2. Next slide, please. So in a nutshell, Damu takes data within a hospital's environment, outside of a hospital's environment, converts that data into useful reports, whereby any stakeholder within the blood services ecosystem can use those reports on real-time basis to make what we call the data-driven decisions. Next slide, please. So whether it's a CEO of a hospital, whether it's a lab manager, whether it's a nurse in charge, they have data that is customized on their dashboard to be able to see what is happening within the blood services value chain at any given moment. Whether you're speaking about any component of blood, they're able to have it at their finger, at a click of a button. Yeah. Next slide, please.
Francis, can I ask you to just wrap up? I know you'll present a sort of metrics to date. Perhaps that's the last one.
Actually, not the last one. That's the last one.
Okay, great.
Yeah, under the potential benefit. Just go back. Please. Yeah. So these are the potential benefits to a facility. Improve the donor management outcomes, improve the visibility of the blood services value chain, reduce waiting times for the clinicians, improve the quality of transfusions, and then there is a faster and more comprehensive reporting, which I've mentioned. Next one. So these are the impact we have been able to make so far, whereby we have supported over 30,000 transfusions and still counting. We have registered over 35,000 registered donors, and this is not counting even those who the facilities are currently registering as we are speaking now. Then we are supporting 87 public hospitals, 45 private hospitals, and also we have saved 2,800 plus units from expiration and cold chain violation. And one point I would like to make on that is that preparing a unit of blood is 17,000. So you can imagine how much we have saved the ecosystem in terms of money when you are speaking about 2,800 plus units of blood from expiration and cold chain violation. Yeah. Next one. Thank you so much. That's the end of my presentation. Yeah. Thank you, everyone, for your time.
Perfect. Thanks, Francis, for walking us through the good work you guys are doing in already so many of the transfusing facilities in Kenya. And with that, we can shift gear and go over and focus on Uganda, where Innocent can talk us through what he and the MScan are doing on the side of maternal health.
Can you hear me?
Yeah, Innocent, we can hear you. If you want to present something yourself, I think we lost the screen, but the audio is good, so please feel free to go ahead.
Just a minute. Thank you so much. My name is Innocent Menyo, the team lead of MScan Uganda. And 5 years back when I was a medical student, I was posted in a raw resource facility to train, my skill sets in terms of ultrasound, X-ray, CT scans, and MRIs. And while at the practice, I realized there weren't no machines or no machines at the facilities. And I also realized a large pool of mothers that were getting complications such as the placenta covering the cervix and were ending up into obstructed labor. We had so many cases of, mothers with oligohydramnios. In simple terms, that meaning the baby doesn't have enough fluid within which to play. And all these are simple things that can be detected using ultrasound. Because these go undetected, today we lose about 16 mothers every day due to such risk factors of maternal health. Not to we lose over 830 pregnant mothers every day due to such risk factors of maternal mortality. And it's quite clear that 99% of these happen in the developing countries, Uganda and so many others. At MScan, we think and we thought on how best we can address this by developing something that can fit in such low resource facilities. And therefore, we proposed an idea to develop low-cost portable ultrasound devices that can work on tablets like this we've developed, that can work on laptops, and that can work on mobile phones. And with the power of MScan, we've seen that we are able to pick up such risk factors of maternal mortality. The mothers are referred on time and the rightful interventions are done, and we have the mother and the baby are saved on time. Of course, there are so many other computers coming up into the market, with Butterfly Network, one of the closest. But we differentiate, of course, with a unique value proposition that we don't only just give the machine, but we also come up with a training model that we do that other computers are not able to do. MScan is purely offline, and we've seen a number of competitors that need internet connection and Wi-Fi to be able to connect to their platforms. So MScan has been designed for the customer, and we designed with the customer to fit best in such low resource facilities. We sell our devices at $2,000 US. That's 10 times cheaper than the conventional ultrasound machines. We know the roads in sub-Saharan Africa are very, very bad. So with our devices, given the portability, we're able to easily transport them, and they're very durable. Can work on laptops, so the laptops are able to power them up, and also the mobile phones are able to power them up. And no need for the iOS. We know iOS is quite high-end when it comes to the frontline health workers. We've seen most of our frontline health workers have Android devices, and with MScan, we can integrate with their device, and they're able to do ultrasound scanning. We identified a need of training, realized that as much as we're developing the machines, there was also a need to equip midwives, clinical officers, medical doctors, basically the frontline health workers in skill sets to do basic ultrasound emergent services. So with that background, we've partnered with Makerere University, one of the best in the region, to train point of care ultrasound scanning. We've trained so far 3 midwives in the low resource facilities, and the results are amazing. We focus for now mainly on maternal health, given our mandate, but there's also room to expand to train in other areas like abdominal ultrasound, pelvic ultrasound, etc. With over 5,000 private clinics and over 2,400 health center 3s in Uganda, we are working in 10 private clinics and 6 health center 3s. We're also exploring possibilities of working in 5 hospitals in Kenya that we are in talks with. We've onboarded a distributor who has access to 9 markets or 9 countries in Africa, and we hope that we can be able to also distribute our devices on a direct sell model in these different countries. Again, we make money through the direct sale of our devices. Before COVID, of course, we're renting out the devices, and this model is still on at $100 per device per day. Per patient per day, and every time the device is used, we earn off that. In the wake of COVID-19, we've launched a home-based ultrasound service. With this, you're able to do ultrasound at the patient's comfort, that's in their homes, also in the community clinics closer to them. So with this, we piloted this with JICA, the Japanese International Cooperation Agency in Uganda, and we saw a 16.3% increment in detection of the complications. And most of these mothers were referred on time with the rightful intervention like cesarean sections done, and these mothers delivered successfully. So we see that at least one of the delays in accessing quality services like diagnostics has been addressed in the facilities where we did the pilot. We are addressing the issue around privacy, walking into patients' home by proposing an ambulance model or the MScan mobile clinic. We shall be able to get closer to the mother instead of walking into their homes or facility. Then we do the ultrasound sessions with the ambulance and also maternal supplies. This is from a case we saw where a mother, after scan, the mother got an emergency, an obstetric emergency, and we couldn't do the evacuation on time with the motorbikes that we had gone with. So we believe that the ambulance model will serve more purpose in reaching out for the impact and us getting more impact in the communities. What's our traction like with version 1, of course, it was more or less like a fetal echocardiogram. It would draw graphs, would interpret the graphs and get informed of the fetal heart rate. With version 3 and 4, we're able to see real-time images, and with these images, we're able to make sense of them, of course, with the training, and we're able to tell the complications arising. Scanned over 1,000 mothers, and we detected over 600 complications with these mothers referred on time. We are also starting to manufacture ultrasound gel, a key accessory with a locally known Japanese company called Sarai in Uganda, and we hope to also scale the distribution across East Africa. We've generated over $25,000 US in sales. That's mainly directly through the hire purchase and some in the direct sale. This is the coverage we've been in Uganda. Entry point for business collaboration. We are currently raising $500,000 US to scale the home-based ultrasound service model and deploy more machines on the lease model or the hire purchase model. Of course, we are scaling the model to also add maternal supplies, like we mentioned, and there is room to co-manufacture with other potential manufacturing firms across the world. We're exploring in Japan and other countries that might pique interest. And we partner with JICA, Outbox, the UN, IDM, Macquarie University, and so on here, where we're trying to integrate artificial intelligence into our ultrasound to accuracy. This is the team, myself, with over 4 years experience in ultrasound, and Phil is the same, and also a research fellow at University of South Wales. Ivan and Joe, our developers and experts in embedded systems. Dr. Prosper is a medical doctor on the team designing clinical protocols, and also a business strategist. This is one of the mothers, where we detected a placenta previa early on time. She was able to do, a cesarean section early on time, and the baby and the mother got fine, and we managed to save them. I still believe that no mother deserves to die while giving birth, and that leads us to our motto: MScan, save a mother, save a life.
Great. Thank you for that presentation, Innocent, and walking us through what you and team are doing in Uganda. There's one question that came in which is on referrals. So in the case of ultrasound scans that show complications in any way, how do you deal with referrals? So you share the information with them, local hospitals, or how does that work?
So integrate with the Ministry of Health guidelines in terms of referrals. So we use the referral notes that have already been, come up with by Ministry of Health to refer these mothers, but also all the areas where we've deployed, we make sure that the clinics have access or contacts to the nearest national referrals or referral hospitals. Like in Jinja, we've deployed in places that are around the national referral, in Jinja, the regional referral in Jinja. So sort of cuts down the time for which the patient has to move from one facility to the other, but also trying to digitize the whole process of referral on how to send the mother from one facility to the other. It's something we're still working on with some telemedicine companies.
Great, cool. So thanks again, Innocent. And with that, let's move on to the last company in the cohort, which is Revital Healthcare here back in Kenya. So let me hand it over to Ronique to walk us through what the team at Revital have been doing and their plans going forward.
Thank you, Tovio. Hi, panelists. Hi, viewers. I hope everyone's doing well. My name is Ronique Bora, and I'm the director of Revital Healthcare, specifically heading the sales, marketing, and product development. Next slide, please, Tovio. So who is Revital and what does Revital do? Revital is a state-of-the-art manufacturing facility located in the heart of Africa, which is in Kenya. We manufacture more than 45 medical devices, some of them being vaccine syringes, COVID antigen test kits, COVID test kits, PPE kits, infusion sets, and many more products. We started off in 2008, where the ex-president of Kenya officially inaugurated the factory. And along the years, if you can see the timeline, we've had several cool accomplishments that we have done. One of them being in 2009, we started manufacturing the auto-disabled reuse prevention syringes. This is actually one of the syringes which are used for COVID vaccination right now. So we're the only manufacturer in Africa to be WHO PQS approved and one of the 7 manufacturers in the world. Along the line in 2012, we started our own line of Vacutainer tubes or blood collection tubes. So we started manufacturing various types of blood collection tubes such as EDTA, plain tube, lithium heparin, etc. In 2013, we received an investment from the Bill and Melinda Gates Foundation, and that is to basically extend our auto-disabled reuse prevention lines to now manufacture different sizes as well. In 2017, with the previous factory that we had, and there's a lot of space constraints, so we decided to build a completely new factory from the ground up, which is ISO and WHO GMP compliant. And since then, we've been able to expand even further. In 2020, when COVID hit Kenya, my team and I, we sat down and we said, what can we do as Revital to create an impact, not only in Kenya, but Africa as a whole? So since then, we started manufacturing, as I mentioned earlier, PPE kits, face masks, COVID test kits, and our latest product being rapid antigen test kits. This year, 2021, we actually crossed our benchmark, which is manufacturing more than 1 billion medical devices. So a very big accomplishment by us and Revital. Next slide, Tovio, please. This is the management team that you see over here. The immediate management team where we have different positions. One of the key factors I want to highlight over here is when we started off in 2008, we only had about 60 people working for us. And what this company and what the management believes in, every single profit that we generate in the company is reinvested into Revital to expand not only the products, but also expand to the countries we operate in. So as of now, we currently employ more than 500 people and 80% of them being women. Next slide, please, Tovio. So since the start of 2007, we've had several international as well as local certifications. As I mentioned earlier, we have WHO PQS. We've also got WHO GMP. We've got 3 ISOs, 13485, 14001, 9001. We've also got CE, which means we can legally export to any country in Europe. We've got Australian certification, US FDA certification for the COVID test kits. In fact, we're the only manufacturer in Africa which is US FDA certified for the COVID test kits and one of 77 manufacturers in the world. In addition to these certifications, we've got Health Canada, we've got Pakistan regulations, we've got MHRA, and many more. Next slide, Tovio, please. So we actually currently export to more than 21 countries around the world, 14 countries being in Africa. And our latest, in fact, just this year, we signed several contracts with companies in Europe. We have the CE certification, and we've never been able to export to any of our products which are CE certified to Europe until early this year, where we're able to get new clients in Austria, Germany, and Switzerland, as well as United Kingdom. So this is a very big accomplishment for us. for the first time in history, all this time we've been hearing a lot of these medical devices are imported from Europe and Asia into Africa. For the first time in history, we've actually exported these vaccine syringes and other medical devices to countries in Europe as well as Asia. Next slide, Toby. So as you can see from the screen, our primary or our core business is syringes, where we manufacture more than a dozen types of syringes, conventional syringes, auto-disabled syringes, reuse prevention syringes. Each syringe has a specific purpose and a specific market. In addition to this, we've also got our new line of COVID-related items, as I mentioned earlier, the latest product being the rapid diagnostic test kits. In addition to this, we also manufacture IV sets, urine bags, infusion sets, blood transfusion sets, vacutainer tubes, and many, many more products. Next slide, Tonya, please. So these are some of the customers that we have gained over the past 13 years. The primary or the biggest customer that we currently have is UNICEF, which is pretty much buying 100% of our capacities of the vaccine syringes. We're proud to announce in the start of this year, we're manufacturing only 3 million units per month, and we're currently expanded to more than 9 million pieces per month. As of February 2022, we'll be doubling the capacity to manufacture 15 million units per month. And before the end of next year, we'll be doing about 35 million units of just the 0.5 ml vaccine syringe. The reason why we're constantly expanding our production range specifically for this syringe is with the recent introductions of the malaria vaccines as well as HIV vaccines, which is going to be a high demanded product. And so that's the reason why we always forecast 1 year before we see the demand growth. In addition to UNICEF, we also supply to WHO. We supply to various governments in Africa, such as KEMSA, government of Uganda, government of Tanzania. We just recently air freighted an urgent shipment to the government of Sri Lanka for the vaccine syringes. And we've got several European clients on this board as well. Next slide, please. So the reason why we set up Revital is based on one fact, which you see over here. More than 80% of the medical devices are being imported into Africa. We see this problem, we see this issue, and what Revital is constantly doing is expanding its product range and making sure that not only Kenya, not only East Africa, but Africa as a whole becomes self-efficient and self-reliant. We have the capability, we have the possibilities, we have the resources. So why not take advantage and make sure that Africa becomes self-independent as such? So since then, since the start of not only COVID, but since the start of Revital factory, we've always constantly expanded our product range. Next slide, Toby. So why is Revital one of the most competitive companies in Africa? We're actually the only manufacturer, medical disposable manufacturer, the largest medical disposable manufacturers for various auto-disabled, for various other products. So there are a couple of factors that are falling into place when it comes to this. Is a lot of most of our products are locally manufactured. We've got a lot of innovation within our company, as well as the associates that we're in line with, such as Kemri, BCG out in Nepal, Vayu Global Health, which I'll talk about later on. And we've also got a lot of values in terms of our structures in the factory. Next slide, please. So what are our competitive advantages? One of the biggest factors that we have is we're quite strategically located in Africa. We have the airport nearby, international airport, we have the seaport, and we have an extensive road network, which means a lot of countries within East to Central Africa, which are landlocked countries, prefer buying from us as opposed to countries in Asia and China. One of the biggest reasons is because we are right there, we're located right next door. We're able to provide the products within a shortest period of time, less than a month sometimes, as opposed to if they were to import products from China and India, it could take anywhere between 3 to 4 months. And with the current logistical nightmare, it could take up to 6 months before a single medical device is exported and imported into any of these landlocked countries. One of the other advantages that we have is being WHO DCIRS approved for the auto-disabled reuse prevention syringes, and being one of the only manufacturers in Africa for the number of products that we manufacture over here. Next slide, please, Tobia. So what you see over here is the testimonials we've received from several customers, not only in Kenya, but one in Canada, 2 in Canada and 1 in Germany. we've been blessed this year to be able to engage with various companies in Europe and tie in partnerships which would lock pretty much 100% of our capacities for an entire year for specific products. So with this in mind, we've also started to focus on an expansion drive where we started to buy new machines and new molds and pretty much double what we're producing right now, which is 1 billion devices a year to 2 billion devices in the next 2 to 3 years. Next slide, Octavio. So as I mentioned earlier, our core business is syringes, where we generate 74% of the revenues as of 2020. We're still growing up ahead, but we're also now focusing on entering into the testing market, which is different types of RDTs, as well as other testing products that we manufacture. Next slide, Tovia. So along the line of manufacturing, what we're doing right now, we've now focused on, as I mentioned earlier, testing. Testing is quite important, especially in Africa. If you want to treat someone, you have to make sure you test the patient first to know what these problems are and how to treat this person effectively. So what we've started to focus on is rapid diagnostic test kits. So we've introduced our first, which is the COVID rapid diagnostic test kits. We're now going for malaria, H. pylori, hepatitis, cancer, and many more such test kits. In addition to this, we've also come up with an oxygen delivery system, which is known as a BCPAP, a bubble continuous positive airway pressure, which I'll talk about this in my next slide. Along the line is our assembly kit. So this is a project that we've focused on in the last 2 months now. And our key idea behind this is a lot of kits like HIV kits or pregnancy kits are actually assembled in India or China, and then they're exported into Africa. So what these companies do, they procure drugs from one company, they procure medical devices from another country, and then they package everything in one kit, and then they export it to Africa, to various NGOs for free. What we want to do is we want to bring this into Africa. We want to import all of these things. If it's locally available, we want to buy these products locally, assemble them, kit them into one beautiful package, and then export to all the neighboring countries as well as NGOs. A lot of benefits behind this. Number one being the job creation, which more than 100,000 jobs can be created in just this single line, as well as, of course, the growth of the economy, several factors which are benefited in this. Next slide, Tovia, please. So RDTs is quite big. There's no such manufacturer that we are aware of in Africa which are doing the various types of RDTs that we're doing or that we want to enter into. We had a visit by the Minister of Health a couple of months ago, and he was quite excited to see that Revital is in the space of not only manufacturing essential medical devices, but is now entering into the space of testing. So with this in mind, we're now, our key focus lies in expansion of testing kits. Next slide, Tovia, please. So the really cool system, which I mentioned about earlier on, is actually a patented technology from Bayou Global Health. So this is a professor from Harvard University who's come up with this very innovative device meant for neonates or infants. This device basically helps provide the right amount of oxygen. So babies and neonates currently at this time of the year with COVID present, a lot of these ventilators are taken to COVID patients. So the neonates, infants are left with no ventilators, which results in brain damage, loss of eyesight, or possibly even death. So with this professor, he's come up with this very innovative product, and he could have gone to China, he could have gone to India to manufacture this at a fraction of the cost. But when their team visited Revital and they saw the facility that we have over here and the settings that we have, the certifications that we have, he actually gave us the licensing manufacturing to produce this product and supply it to the world. This product is actually going to be placed in the WHO and UNICEF catalogs, and we're also talking to several international organizations such as UNITAD and Saving Children to procure these essential medical devices for the continent. Next slide, please, Tovia. So these are the recent partnerships we've had. Auda Nepad, I'm sure everyone knows Auda Nepad very well. They've been helpful this year, and we've actually been able to gain a lot of knowledge from them. And we thank you, BCG and Auda Nepad, for this opportunity. As I mentioned earlier, regarding the Bayou Global Health, Dr. Thomas Berg, where we're in partnership with the BCPAP system. And recently, in the past 2 months, we've actually had investors invest in Revital. So they've become an official director over here. And this is actually one of the biggest pharmaceutical companies in Japan, which is Ohara Pharmaceuticals. So with this in line, we're now looking into entering also into the pharma sector and not only the non-disposable sectors. Next slide, Tovia.
Great. I think that's it, Ronique.
Okay.
Cool. I actually did receive a few questions, two that are pretty sort of in general. The first, I think, must be on many people's minds. What's it been like to sell syringes during a pandemic?
It's crazy. I mean, I've gotten so much white hair because of this, and I'm only 30. So it's a challenge because everyone wants syringes right now. There's very few manufacturers in the world which have the right certification. And with this in mind, capacities are constrained, demand is extremely high. So we foresaw this about 6 to 8 months ago when we knew the vaccines were going to come out. And what we focused was in an expansion drive. So since then, we've now expanded to manufacture more than an additional 30 million units per month of various sizes. And we're still expanding because, as I mentioned earlier, we have COVID vaccinations right now, which are very soon going to be required booster shots. But very soon, the malaria vaccine is going to come out, which are going to require 4 shots. HIV vaccine is going to come out too as well. So which is going to replace the ARV drugs, and you will require 2 shots per month for the HIV. So we see this demand, and because of this demand, we're always constantly expanding.
Gotcha. Thanks. And then another one is actually linkage of your products to the other 4 companies that presented today. Do you know how many of those 4 use your products?
I've actually, I'm not sure if any of these companies use my products, but I hope to God they start using my products now.
Nick, go ahead. I see you raise your hand.
We
want to believe in the motto of buy Africa, build Africa.
I think we buy from Neomedic your syringes, so I think it's about time we just buy direct. Given we have distribution licenses, let's make a deal.
Absolutely, Nick. Looking forward to speaking to you.
We're doing about 500,000 syringes for next year.
And the other one I've actually seen in pictures so far, and Francis, you can probably confirm it. I've seen in many of your blood drives, there's also plenty of Revital boxes around.
That's awesome.
With that, I think one question to the wider panelists that came up a few times before we go over and we allow them more sort of meet and greet breakouts. And that's been, and Daphne, if you're still with us, I might ask you to start answering it. If not, Nick and Ronique or Francis, anyone else can join as well, but it's around the push for universal healthcare and the discussions that are now going on in Kenyan politics. And what's it like working with the government and the NHIF to achieve sort of real world impact for patients? And Daphne, if you're on mute, Nick or Ronika might ask you to kick us off.
I can take that.
Yeah, please.
Okay, on the UHC, looking at the objectives of Damu, like, let's say a facility collects like, let's say 10 units of blood, and then we have a regulator such as the Kenya National Blood Transfusion Services. We are looking at how can we make it possible for the distribution to be based on need as opposed to equal distribution, whereby I'm able to mirror these facilities within the Damu platform to ensure that if we are, because UHC speaks about equitability. So are you able to distribute these units of blood like on a need basis as opposed to even distribution as what is happening currently? That's the discussion we are having with the Kenya National Blood Transfusion Services. And when we are speaking about the aspect of blood, it's really a sensitive matter, as you are aware that people do not pay for blood. So it's a discussion that we have with them every day. And the good thing is that they are open to this discussion and they see value that Damu Sasa brings into the ecosystem, especially as far as the aspect of UHC is concerned. Yeah.
Thanks for that. And Daphne, how is Access Afia sort of thinking about that?
I'll make a comment on universal health coverage. So I think you might be familiar with that in Kenya. That's a kind of key agenda. It's a plan that's in action in several phases, and so for us at Access Afia, I'll say that so the pricing under which the national health insurance has kind of capped the fees for primary healthcare providers is $12 annually. So this is kind of makes it difficult for a lot of primary healthcare providers to or private sector players to take. But for Access Afia, this is an amount that has worked for us and that we're continuing to work with because of our low cost model to deliver the scope of services and benefits to members under NHIF. So health financing in general and universal health coverage is a huge enabler for our model, really strengthening our ability to grow and expand into areas that even NHIF is increasing and universal health coverage is increasing their access in.
Yeah, thanks for that, Daphne. Then when it comes to the price of insurance and how that plays to your business model, Nick, I'm sure that's also something that you have on your mind in these various countries all the time.
Yeah, no, I think the reality is for us, given the cost of dialysis, it's very difficult for most countries for us to enter countries that don't have a national health insurance scheme or universal healthcare coverage in the works. So Kenya, Tanzania have very prominent UHCs and national health insurance funds, which have allowed us to enter into these markets. It's extremely important for us because of the fact that they provide comprehensive coverage, but there's a need for things and initiatives like UHC to provide risk spreading. Otherwise, there's adverse selection whereby patients who require dialysis will only sign up for NHIF 6 months before requiring care. So it's a delicate balance. I think right now we can't bite the hand that feeds us as well. And so we need to ensure that as countries are adopting national health insurance schemes, they're doing so in a disciplined manner, such that they don't effectively bankrupt the fund. And the two biggest costs right now within NHIF are two of the five largest are oncology and nephrology, so dialysis and cancer treatment. So for us, as we look around, Zambia has now implemented an NHIF, Uganda is talking about it, South Africa is looking at it. So as we look around, there are two forms of kind of health insurance that will really, or health coverage that will really take the kind of lead in sub-Saharan Africa. One is state funded. You go to public hospitals and you receive care free of cost, or it'll be through a scheme such as the National Hospital Insurance Fund in Kenya or a National Health Insurance Fund in Tanzania.
Yeah. Thanks for that. Now, perhaps one last question before we go to the breakouts. And Ronique, I think you may have seen this as well come in on the chat. It's about innovation in green manufacturing for your production. So please, over to you.
We are actually looking at a green manufacturing with the current, which I'm sure most of the Kenyans over here will tell you, the electricity bills right now are ridiculously high. And because of this, we're starting to look into solar, which is the best resource available right now in Mombasa to get naturally. So we're looking at solar right now to power the entire plant. So hopefully before the end of this year, we should have it up and running.
Awesome. Cool. No, thanks everyone for also this sort of quick plenary discussion at the end. And now to make it interactive also for our attendees, what my colleague Bayeta will do is share links to breakouts. Everyone should see them come in right now. I'll ask the sort of entrepreneurs here on the line to go to the one for their companies, and then any attendee feel free to join one for meet and greet, potential follow-up questions as well. We'll leave them open for a bit, so feel free to sort of join those as you see fit. And then Bernice and myself will be in one on the Accelerator as a whole in case there's also questions on that. There's no scripting to this, so please just jump in, ask your questions, say hi, and with that, that also makes it a bit of a sort of informal end. So thanks everyone for attending, and yeah, hopefully some more nice meet and greets and good things will come out of this. Any questions, always feel free to reach out to us. So thank you, and let's chat further in these personal breakout rooms. Thanks, Ronnie, Nick, Francis, Innocent. It's been a blast.
I'm struggling to join the breakout group, but let me try this again.
The breakout session on my side says the host is still in another meeting.